Hi, I'm Dr. Robert Kaufmann, and it's time for us to go beyond the terminus. How big should you make your endodontic access? This has become a very controversial point lately. There's no question that clinicians performing endodontic treatment must regard tooth structure with greater respect than we have in the past. Historically, endodontics was mostly thought of by clinicians as someone independent of the restorative treatment plan. Endodontists felt the treatment took priority because, after all, if the periapical pathology or symptoms didn't respond to endodontic treatment, it didn't much matter what kind of restoration was being placed on the tooth. The patient complained that they couldn't use it comfortably. For almost 50 years, endodontists have been trying to convince general dentists to open their access cavities to be able to adequately see inside of their teeth. Many endodontic failures occurred because of the inability of clinicians to be able to see, recognize, or treat endodontic anatomy. The inflexibility of early carbon steel and later stainless steel instruments and the acknowledgement of the need for better cleaning and shaping of the canal systems all led to larger canal shapes that sometimes contributed to root fracture in the past. It's ironic that after so many years of endodontists advocating this philosophy, we now see the exact opposite, an emphasis on smaller access cavity design and more conservative canal preparation. The simple fact is this: the specialty has evolved. With better metallurgy and imaging techniques, it became possible to scale back the canal size. There are certainly many talented endodontic clinicians who can perform endodontics through these more restrictive accesses, but my concern is for the 80% of the endodontics that's performed by the general dentist. The use of the surgical operating microscope is now standard in the endodontic specialty. In 1998, the Commission on Dental Accreditation included a microscope proficiency standard for postgraduate programs. If you want to read more about the use of operating microscope in endodontics, check out Dr. Carr's fantastic article in the Dental Clinics of North America in 2010, volume 54, pages 191 to 214. Whereas in the past, endodontists tended to open the access to allow for better visibility, the surgical operating microscope has allowed us to downsize the access while still maintaining optimal visibility. However, general dentists wishing to emulate such minimal access cavities without the use of a surgical operating microscope and associated lighting are going to miss anatomy, and this will result in symptomatic teeth. My fear is that these teeth will remain symptomatic or fail and never reach the office of the endodontist for retreatment. They will instead be extracted and replaced with an implant without ever being seen by the endodontist. Therefore, general dentist attempts to emulate such accesses may in fact contribute to the perception that endodontic treatment doesn't work or is less predictable implant placement, much to the detriment of our specialty. The controversy remains: how conservative can we be while maintaining success? The latest endodontic philosophy implies that endodontics should be restoratively driven. By this we mean that every effort should be made to preserve tooth structure if at all possible. These newer access cavity designs would have been considered inadequate by my undergraduate teachers many years ago, and they're still somewhat controversial. The endodontic treatment must be thought of as part of the total rehabilitation of the tooth. In that respect, advocates do have a point. However, proponents of this minimal access technique fail to mention one very important point when discussing this: the need for adequate magnification and illumination. If you're going to try to make these ultra-conservative accesses, you cannot do it without a surgical operating microscope and strong light source. Loupes are not enough. I believe that anybody who teaches courses or gives lectures advocating these more conservative techniques and does not insist that the clinician use a surgical operating microscope is doing the specialty of endodontics a disservice. This minimalist access philosophy is derogatively referred to as a ninja access by its opponents. Many critics think of this design as a vanity project. Look at how good I am. I can preserve tooth structure by working through this tiny little hole. There seems to be a fascination with how small can we go, as if this was some measure of how talented the clinician is. In the case of access through a crown, how much actual tooth structure is being saved by restricting the access through the existing restorative material? And the tooth that has restoration that is going to be removed because it's inadequate, or those that will be replaced after endodontic treatment, what purpose does it serve to preserve the material during access? So to those who suggest that we should be moving toward more conservative access cavities, generally I agree, with some caveats. Smaller accesses have some problems. We know that endodontic irrigation, with whatever technique that you use, has its limitations. Irrigation efficiency is based upon time, volume, and turnover. Vapor lock, which is the creation of an air bubble at the end of the prepared canal, long, thin canals, and even the surface tension of the solutions themselves make it difficult for irrigants to reach the apex in adequate volume. Yes, there are some machines and techniques that claim to do this better, but research, not supported by the manufacturer, paid consultants, and anecdotal evidence is what is needed. In the rush to get these expensive machines to market, instead we get opinion, frequently expressed by sponsors of the research, paid consultants, and anecdotes from users. As with most things, the pendulum will likely settle in the middle. Hopefully, the overly large endodontic accesses of the past will be replaced by accesses that are large enough to allow both the surgical operating microscope and non-surgical operating microscope equipped clinicians sufficient visibility to properly perform predictable endodontic treatment, while at the same time respecting the need to conserve tooth structure that allows for better long-term structural integrity of the tooth. As always, case assessment prior to starting the treatment is better than referring a hogged-out, physically weakened, unsalvageable case to your endodontist. Remember, when we do the right thing, we both get better, patients and clinicians. Please remember to subscribe. Don't forget, it's free. Thank you for watching, and I look forward to seeing you again the next time when we go beyond the terminus.